Good afternoon, everybody. I'm Alex O'Neill, Code's Professional Services Manager and Head of Compliance for Code. Welcome to today's webinar, which is the new CQC Key Lines of Inquiry in 2018. So hopefully, first webinar on this topic. We will do more later on in the year, and obviously we've got our CQC Update Day in September where we should know more of this. This is going to develop, so this is sort of the first take of what we think is coming. Some things seem quite obvious they're coming, some things we're sort of reading between the lines. But hopefully this should help you you might not need to actually do anything after today, apart from just sort of prepare, or maybe you will need to do quite a lot after today, depending on the information that I give you. Hopefully those with iComply, obviously we've got a mixture of people in the room, some with iComply, some without iComply, and obviously those who have our software and follow our systems, we will be keeping this up to date for you to make sure that it's very easy to implement any changes before they come in next year. It's verifiable CPD for our iComply application subscribers. So we have to have aims and objectives. So the aim today is to increase understanding of inspection regimes and help practices prepare for inspection. That's pretty much our aim with 99% of the webinars that we do. The objectives, so how are we going to achieve that? We're going to explore code research a little bit. We're going to discuss the proposed changes to the key lines of inquiry. So I'm going to go in and look at those and talk about those in quite a bit of detail. And we're going to explore how the iComply application and Code's quality practice scheme will help you reduce risk and the relationships between those two things and the changes that are coming next year. So learning outcomes. Hopefully by the end of today you'll understand the upcoming changing to the KLOEs. There are a lot of changes, so we've only got 50 minutes, 45 minutes today. So there's a lot of stuff that I couldn't include that I wanted to include. So we could see today as sort of a top level, a first look at those changes, and then we can dive into more detail in some webinars in the future and events that we're doing. And you can prepare to make changes ahead of April 2018. You may need to make some changes, or you just may need to prepare and start thinking about what you can do to be ready for next year. So code research. As always, we're doing ongoing research and we're looking at the inspection reports that are being published. Those of you who have been following this entire webinar series, I think this is webinar 19 or 20 now, so we've done quite a lot over the last 2-3 years, have been probably seeing the progression of this. So we've now looked at over 1,800 inspection reports that were published up until the 2nd of June. And what we've seen from that is 15% of practices over that time period who have been inspected are in breach of at least one regulation. They've failed their inspection and they must make improvements. And 69% of practices, it's quite a high number, are being told that they could and they should make improvements. Though they haven't failed, but they've been told that they need to do a little bit more in certain areas. Now, for that 15%, it's quite interesting that originally, when the new regime came in, that number was 20%. And what we've actually seen over the last 2 years is that number is steadily going down. So it started at about 20%, and now month on month we're failing the inspection, and now it's about 15%. So it's the inspection's getting bedded in and people are getting used to what it's about. But we're still seeing, the people who are failing, 89% of them are failing on being well led. And with these KLOE changes we're going to look at today, the CQC are strengthening well led. They're adding more to it. So that's going to become, so well-led is still the sort of focus area for practices. They really need to get a grip on their leadership and on their governance. And I'd really recommend that people go and look at the top 5 reasons practices fail inspection webinar, which is on YouTube now, where I talk a lot more about well-led governance and leadership and what the CQC are looking for, in our opinion, code. So, safety obviously is the other big issue. I did see another speaker talk about this recently, which was quite interesting, and what they said was that quite often, in their opinion, the CQC would rather fail you on being well led than fail you on being safe. So sometimes if the safety breach was caused by a lack of leadership, then your breach will be on that side on your report. And the main reason for that is because if the local media gets hold of the fact that you failed on safety, then I think I've said it in other webinars, if you go and Google dental practice found unsafe, what you'll get is a lot of websites for local press in different places, Middlesbrough and other places I've seen, where the local press will get hold of that CQC inspection report and will make an example of a practice in the press saying that they failed on safety. I think we've spoken about this before, but the iComply application practices, people with our application in 2016 had a 97% pass rate, so above average for people who are using our software, which we're very, very proud of. Right, so new focus areas. Well, actually, it's quite interesting because what we do is every time we do one of these webinars, I go and I look at the last sort of 20, 30 inspection reports that have been published that have been really bad failures, to look at why practices have failed. And usually that's where we found these trends that have been coming out, and we've been able to, or one of the places that we found these trends that are coming out, and we've been able to react reasonably quickly here at Code. What I actually noticed this time is that there was nothing new. So it looks like, as I've said at the bottom point there, the new regime is kind of stabilised now. So we're not really seeing a lot of new compliance coming out in the inspection reports. Couple of things which are being spoken about more by people is, the first one is obviously CPD. Having good CPD records and making sure that everybody who is GDC registered is up to date with their CPD is a requirement of being a provider, and the CQC are looking for that in practices. So just make sure you've got good CPD records. Domiciliary visits, the CQC aren't looking at this currently. The reason I put this on here is that it's being raised as a question by us and by other people to the CQC, because a lot of people do ring us up and say, how can we do domiciliary visits? And actually, if you're going to do a domiciliary visit, then technically, because you're taking an employee, you'll be taking a nurse, you need to risk assess anywhere that you would, if you're following the sort of the CQC and the risk assessment way of doing things, HSE way, then technically speaking, you're supposed to risk assess before you go in to anywhere or take an employee. And obviously this is causing a block for practices that want to do domiciliaries every now and again. So we're waiting for feedback on that from the CQC, and they are very aware of that, and they're looking into that. Then I just put these 3 bullet points together because the CQC just published a Mythbuster on the Equality Act and the Accessible Information Act and sort of interpreters and what practices are supposed to do. So a lot of people do ask, if I have an NHS practice, am I supposed to pay for interpreters? Because that would cost a fortune if I can't pass, because obviously we can't pass that on to the patient. So I would advise that you go and read the CQC Mythbuster on this. The Accessible Information Act is something that NHS practices have to comply with, that came in the end of last July the 31st last year, and the CQC have said in multiple publications a few times that they're going to start regulating this and looking at it, but I've not actually seen them starting to look at it yet, so I get the feeling that they're letting practices get used to it and make sure that they've sort of been giving enough time for practices to actually start following the Accessible Information Act. If you are an iComply or a Code member, then we have a policy for that. It's M233-ACI, so that's Alpha Charlie Indigo, so you can have a look for that. Right, so topics for today. So what we're covering is, obviously there's been a consultation by the CQC, and out of that, in part of that consultation, they've proposed new key lines of inquiry. There's this thing coming called insight monitoring, which is basically the CQC's almost risk score for your practice. So you want to think of that almost like a credit score for your practice. I think that's the way I sort of visualize it best, is that the CQC will have a sort of a risk score for your practice that can be positively or negatively affected by certain things. And in the future, it seems that when that threshold hits a certain level of risk, that may possibly trigger an inspection. So we'll be talking about ways to sort of maybe keep your risk down. Part of that is accreditation schemes, and part of that is managing your online information, anything that's publicly available about you that they could look at. So as I said, risk and accreditation schemes, and I'm going to be reading between the lines a little bit, so this is not definite, about a more self-regulated future. My sort of prediction for the future dental regulation is that we're going to become more self-regulated. We're going to have to do sort of annual returns, I think, so we'll see. Okay, so consultation. So in December last year, December 2016, the CQC published this consultation document called Our Next Phase of Regulation. They did say in the document that they were going to publish a second consultation in spring this year, and that was going to focus more on adult social care and primary medical services. This one focused on a lot about sort of cross-sector and NHS trusts, but they don't mention dentistry a lot. So we're kind of having to read between the lines and figure out what's happening with dentistry. Now, I thought when I read this in December that what we would have in spring, when they said they were going to do a second consultation, would be something that would focus on primary medical services and hopefully primary dental as well, or they're incorporating that, but we've not seen that happen yet. One of the big things they've said in this consultation basically is safety is their biggest concern and leadership. So what we're going to see a lot of going through these next slides is things about safety and leadership. So we're going to be talking about those two quite a bit. Okay, so changes. Inspection timeframes, don't worry, please don't panic. There's no change to inspection timeframes for dental at the moment. What they've really said, but I thought questions might come up about this, so I'll put this on here. What they've said is that dental practices, they will still inspect a certain number annually for now, and then they will inspect others based on risk, and they're still figuring out what they're going to do about dental practices. So I would still say, imagine at the moment you're probably going to get, if you plan that you're going to get an inspection every 3 years or so, then you're going to be safe. With GP practices, what they've said is that they're going to try and extend the maximum time between inspections to 5 years for GP practices, and that will be based on previous ratings. We don't have ratings in dental practice, but that will be based on previous ratings and also on risk. So I think we'll probably follow suit with that for dental practices, but for now, if you just imagine that it's going to be the same on the sort of frequency of inspections. Now, what they've done with this consultation is they've taken 11 sets of key lines of inquiry, KLOEs, and they've turned it into 2 sets. So I don't know how many of you have read the Dental Provider Handbook. It's a really, really good document. But in the Dental Provider Handbook, it has all the key lines of inquiry and inspection prompts for safe, caring, effective, responsive and well-led, and examples of evidence and how you meet those inspection prompts are all in this quite nice document called the Dental Provider Handbook. So there's been a provider handbook for dentistry, for medicine, for ambulance services, and they've got 11 sets of key lines of inquiry with 11 sort of 11 interpretations of what that means for that sector. Now, what they've said they're going to do is bring these all together, and they've published 2 sets, one for sort of a social care, which we don't need to worry about, and one for healthcare, which we do. And they've made 125 changes. So there's quite a few changes, which I'm going to talk about. They've also added 3 new well-led key lines of inquiry with inspection prompts. So there's a lot of changes to well-led. I'm going to touch on some of them today, but I think that could actually be a whole webinar in itself. The other thing is they haven't included examples of evidence. So whereas now what we have currently is the Dental Provider Handbook, which has lots of examples of evidence for how you meet certain things, they've not put those on this new document. So I'm not sure if they're going to take those key lines of inquiry and inspection prompts and create a new Dental Provider Handbook that we've not seen yet. But obviously they've got until April next year to do that. So I will be talking about what I think maybe will be examples of evidence around things that are coming. And some of them are quite obvious and some of them not so obvious. Right, so increased focus on well-led. As I said, they are increasing the focus on well-led, and you can see there what they've said is they're doing this because they're clear that there is a demonstrable link between leadership, culture, and the delivery of safe, quality care. So they've realised that if you've got poor leadership in a practice, unclear leadership, if the leadership doesn't understand what compliance is about, or doesn't even like compliance, then that will flow throughout the organisation and you will have a poorly led practice that maybe isn't safe. So they are toughening this up, and they're looking more at leadership, and they're looking more at culture, and they're looking more at capability and capacity of leadership, which we'll cover a bit later. Okay, so as I said, there's 125 changes to the key lines of inquiry. Now, you can see down there, well led has had 19 new key lines of inquiry or inspection prompts, 23 changes within the key line of inquiry in the inspection prompt, and 1 movement. So all of those together is 125 things that are either new or changed in that draft document, which I'd encourage you to go and read, by the way. Obviously, it's nice to watch a webinar and get my sort of code's take on for 45 minutes on this, but those documents are out there in the public domain, and as registered managers, responsible people, one of the key things is that you understand the regulations, because that's your job. Your job as the registered manager is to make sure that the regulations are met in the practice. So if you don't know what the regulations are, then does the practice stand a chance? So I'd encourage you to actually go out and read this stuff as well. Okay, so I'm going to sort of dive into these a little bit, and we're going to look at, I've got about 3 or 4 slides on some of these new ones and these changes and what I think they could mean and what some of them quite obviously mean. So the first one we've got there, and I will be sort of reading off my screen to the left slightly, is how is safety promoted in recruitment practices and through ongoing checks, for example, DBS checks. Now, the interesting thing here is that it says ongoing checks. So right now, quite often at Code, we will get asked this question of how often are you supposed to have a DBS check done? And technically there is no, once you've got it once, there's no requirement in any regulation to get it done again. So this looks to me very much like they are going to be introducing an ongoing requirement to regularly update DBS checks, which kind of makes sense, because if you ask most people will say, well, it's every 3 years, but there's no rule that says every 3 years. In Wales there is, but in England there's no rule, but it's kind of, how can I put it? It's kind of the profession's norm to think that it's every 3 years. So I think the CQC will adopt that, and I think that what we will start to see is that this ongoing requirement comes in. To be honest, I would just put team members on the update service. Self-employed team members will pay for that, obviously, and employees, you will pay for that. And obviously that's going to then make sure that if anything happens, that the practice is alerted. So that's that one. Moving on to the next one. How are staffing levels and skills mix planned and reviewed so that people receive safe care and treatment at all times? I mean, that's already in there, but then they've added this little bit, and staff do not work excessive hours. Now, I'm an ex-practice manager and I've worked in quite a few practices, and I wouldn't say that it's unusual for, say, maybe 1 dentist per practice to have, let's say, not ideal timekeeping, and you've got that one poor nurse who is constantly in surgery every day, 12 hours straight. And if the CQC asked that person, do you work excessive hours, then you probably wouldn't like the CQC to ask that particular person. So I think what we're actually seeing, you'll see this in other KLOEs as well, is the CQC are going to be looking more at talking to your team members, making sure that they're happy, they feel supported, they feel looked after, and that the practice is managed and led in such a way that doesn't mean that your staff are working excessive hours. So you might want to, some of you, we've got 200 people in this room, some of you that might be something you need to address in your practice. I won't ask you to say yes if you think that it is. I would maybe, if this was in a room, I might ask for a raise of for hands to go up, but we won't do that. Okay, so at 6.5, now this is, for those of you who have iComply, we've seen this a lot this year, is the CQC are looking at safety alerts and seeing how practices respond to them. So, you know, if you've got a CQC inspection coming up, I can almost guarantee you that the CQC are going to come in and ask to see your safety alerts folder and how you managed your safety alerts, and if you can't show that evidence, that could go against you in the inspection. So this is why we released a new version of our safety alerts policy about 2-3 weeks ago, which is M233-SAL. So SAL, the safety alerts policy. So if you've not put that on file yet, I'd highly recommend you do that ASAP. But what's interesting here is that they've said, are these audited? So what we could see, which you don't need to start doing yet, this is something that obviously we would create for you if it becomes a definite requirement, but we could see that a requirement to actually audit your safety alerts and audit your any recalls, investigations, reviews. So that could be a new audit that's going to come in that we could see. So we'll watch this space on that one basically. S3.2, this is something they're already doing. So what we've seen a lot, what I've seen a lot in these new KLOEs is a lot of the stuff that they've been doing in inspections but wasn't quite clear in the KLOEs, they've now actually put into the KLOEs almost retrospectively. So they're making sure that your blank prescription forms, your NHS forms, stored safely and tracked in line with NHS Protect guidance. I won't go into that now, but you need to essentially log every single page of every single form into the practice and then out once you prescribe it. Okay, so effective and responsive examples. So moving on from safe. E3.1, which has changed there, is do recruitment processes ensure that all staff have the right qualifications, skills, knowledge and experience when they start their role? That's in there already, and that's quite obvious, and that's being checked. However, it's quite interesting, the next bit, which is how is this assessed on an ongoing basis? That's appraisal, which we know we're doing already, but more importantly, or when staff take on new responsibilities. So this is something I've spoken about in a few webinars, but I think it's really, really important that when we do give a team member new responsibilities, we make sure that we support them to do those responsibilities. We don't just take our longest standing nurse and make them the infection control lead, because maybe they're actually not up to date with HTM 105. They don't know what it means to be an infection control lead, and as in the infection control lead, they're going to be responsible for, say, doing the infection control audit every 6 months. And the CQC, I did read on one inspection report the other week that the CQC were actually looking at the infection control audit and checking individual lines on the audit against evidence in the practice to see whether the person who carried out the audit had done it accurate and whether they understood what the questions mean. So it's always a good question for your practice is, does your infection control lead, who's responsible for, say, doing your audit, know what the right answer should be, or the correct answer is, the compliant answer is, on every question on the infection control audit. So making sure that you're supporting people when they're taking on new responsibilities. Do staff have appropriate training to meet their learning needs and cover the scope of work? Is there protected time for this training? So they're looking to make sure that you're giving protected time to your team members for training. Now, I'm going to put this in an iComply perspective because I think it's quite an interesting one. In iComply, if you're an iComply practice and you're following the monthly cycle, then each month you have a training meeting. That is your practice meeting where you are supposed to protect that time and deliver training to your team on the policies and the procedures. Now, what we quite often find when we audit practices is those meetings are not protected. They are, if a patient rings up in pain, the meeting is the first thing to get cancelled. And then we see practices that are actually signing off doing all their policy reviews, doing all their procedure reviews, but they're 5 months behind on their meetings. So I think under these new key lines of inquiry, that would be frowned upon because you have protected time and you're actually you're not following it. So I would advise you, if there's a small adjustment now, maybe start considering those meetings to be sacrosanct. And actually, you'll see later on, I think it's on the next slide or the slide after, there's another reason for that. So what action is taken to minimise the length of time people have to wait for care, treatment or advice? Doesn't sound massive in itself, but this could be the CQC going to be looking at your diary management. Just to see how well you're managing your diary and what you're trying to do to actually or how you're managing your businesses or how you're trying to expand to have more capacity in your business. It could also be the length of time people have to wait when they're sat in your reception, because the CQC do look at those things. And I did read a report, I think it was yesterday or the day before, when a practice had done a patient satisfaction survey. The satisfaction survey had basically found that it was a common problem that patients were waiting too long, certain clinicians were running late. So the practice has said, right, we need to do a waiting time survey to resolve this, and then the waiting time survey was never resolved. They never carried out the waiting time survey. So that's an action that's come out of a quality assurance activity that's not been dealt with, which, as we know, is pretty bad at the moment. So I'm just going to have a sip of my water, my throat's getting a bit dry. You're all very quiet today. I've had no questions so far, apart from a couple of document ones, so hopefully I think everyone's listening to the end, and then we're going to get a flurry of questions, which is good. That is better that way. So, is technology used to support timely access? Is the technology, including telephone systems and online digital services, easy to use, and does it support people to access advice and treatment? This is something that has cropped up on a few reports, so it's quite interesting to see it actually going into the key lines of inquiry now. I think a good example would be if you're a 5-chair practice that doesn't have any sort of a hold system and you have one receptionist with one telephone, then you're going to come a cropper under this key line of inquiry. So it's making sure that you've got the right admin and reception team and phone systems and online systems to actually cope with your patient base, which some practices don't have. I mean, occasionally I'll be asked to call a member. It doesn't happen often, and I can't get through to that member for about a day and a half or something like that when they've got an inquiry. So if you think that could be you, if you think your phone system is out of date, then maybe you need to start looking at that. Maybe you need to explore online options so people can do online booking for you. So maybe that's something you need to start thinking about right now. Okay, so well led. Now, I would flick back to that slide, but it's a few slides ago, but you can see how many changes. There were, 50 odd changes to well led. So that, as I said, that probably could be a webinar all in itself. Let's explore a couple of slides and just see what they're saying. So well led 1 has changed and now says, is there the leadership capacity and capability to deliver high quality sustainable care? Now, the interesting words there are capacity and capability. Are the leaders capable of doing it? If you sort of delve deep into the CQC literature, there's actually a requirement for registered managers and responsible people who are legally responsible for making sure that the regulations are met to stay up to date with what the regulations are. And I'd always say to principals or registered managers, again, decon leads, is do you know what the regulations are? Do you know what your job is as the registered manager? And your first job is to understand what the regulations are. So do you understand what the regulations are that you're supposed to be managing? And if you don't, then you don't necessarily have the capacity or capability at the moment. But that can be learned. So you probably want to go on courses. The CQC are looking at this more and more, and we're seeing it more on reports. And if you see the top 5 reasons practices fail inspections webinar, I talk about it in there about poor leadership. You know, we have practice manager conferences that are going on later this year. I think Cliff will put the link up. We also have our CQC update day and our HIW update day, which would be great training for people who are in those roles. So that might be something you want to consider if you think that you need to stay up to date. We do these every year, and there's certain managers, there's probably 20 of them in the room that I can see right now who come on these days every single year and have a very, very good understanding of compliance. Right, so the next one, well, capacity as well is quite interesting because, again, if you've got a small corporate, if you've got 10 practices and you've got one compliance manager who's the registered manager for 10 practices, then that probably won't work anymore. Even 3 practices is a bit of a push without good sub-managers in the practices. So they're looking at those sort of situations more, where you've got a registered manager for 3 practices. Can they actually do that role? So with W1.2, do leaders understand the challenges to quality and sustainability, and can they identify the actions needed to address them? I mean, that's quite, if we could unpack that, there's a lot in there. In order to understand the challenges, you need to understand the regulations. So that's the first step, as I said before. In order to to identify what's going wrong and fix it, you need a decent governance system, be it iComply or another system, but you need a system that makes sure you don't miss anything and you identify the problems and you can deal with them. Which is a lot more about the well-led key line of inquiry. A lot more what they're looking at now is your systems, your governance systems, your policies, your procedures, your actual system to make sure that everything stays up to date and you don't miss things and you deal with anything that goes wrong. W3.3, this is very similar, tied in with the more of the staff focus that I was talking about before, but do staff feel positive and proud to work in the organisation? That's a key line of inquiry, that's an inspection prompt now. So, you know, in iComply we have the staff satisfaction survey. Again, if you don't use iComply, I'm sure you can come up with a staff satisfaction survey. But you want to ask your team members, are they proud? Do they feel positive? What are the problems? One of the key lines of inquiry that I haven't put on here is that they say when looking at risks, when the CQC question your staff and ask them what they think is wrong in the practice and needs fixing, does that match up with the action plans that you have on file? So they'll see very, very quickly if you're not listening to your team, or if you're not even considering. You may decide that the team's concern is unfounded, but if you've not got any written evidence that you've considered that, that could be something else that they will look at. Are there clear responsibilities, roles, and systems of accountability to support good governance and management? So I've spoken about this in a few webinars, but they're really tightening this up now. So does everybody know what their role is? Does the complaints manager know that they're the complaints manager? Does the receptionist know that the practice manager is the complaints manager? Does the complaints manager know what they're supposed to do with complaints? So are all the roles clear? Are they clearly defined? Are they clearly communicated? Does everybody know who's responsible for what? And is there a system of accountability? And is there good governance and is there good management? And obviously, that's what iComply is all about. Some more well-led changes that we can go through. Are there clear priorities for ensuring sustainable, compassionate, inclusive and effective leadership? And is there a leadership strategy or development program which includes succession planning? So they're going a lot more on the sort of the strategic side of leadership and management. And obviously one of my tips for that would be we have optional leadership and management modules and activities in iComply. If you're coming up to the end of your cycle and you're going to start a new cycle, then maybe put in those optional leadership activities. Create a mission statement, create a strategy that includes quality as one of your objectives and communicate that very clearly to the team and let them know what their role is within that. Are there effective structures, processes and systems of accountability? Oh no, sorry, I think we already looked at that one. Are there comprehensive assurance systems? And are performance issues escalated appropriately through processes and are these regularly reviewed? So do you have a proper quality assurance system in place and do you respond and react to things? 6.2 is quite interesting because this ties into what I was saying about iComply meetings earlier, but is quality and sustainability covered in practice meetings or in meetings at all levels? Do all staff have sufficient access to information and do they challenge it appropriately? So for example, in iComply, every single meeting has a prompt to discuss issues with team members. We already have that in the system. And we're discussing quality in all of our meetings. That's what it's all about. Quality, you know, we have points to discuss any actions arising from risk assessments, audits, any quality issues to be discussed. So CQC looking more tightly at that. And then the last one there is, are information technology systems used effectively to monitor and improve the quality of care? Now, obviously that can't be an absolute requirement. The CQC can't ask you to invest in a system. But it's never a bad idea to invest in a quality management system. Okay, so insight monitoring is the next thing that I want to discuss after the key lines of inquiry. Basically, the CQC have this thing currently called intelligent monitoring, and what they've said is they're moving to this thing called insight monitoring. And obviously there's a statement there that you can read on the screen about what it's about, and they're saying that for this is about GP practices, this particular quote, but what they've said here is the insight model will support an increase in the maximum interval between inspections for good and outstanding practices. Now, we do not get ratings, and it doesn't look like there is going to be a change currently for us to get ratings. However, I don't think it's a far stretch to imagine that the CQC has some sort of internal rating for us, like a risk score and an inspection score. I imagine that they would have. So this insight monitoring system is an intelligence system that looks at information that the GDC have about you, the NHS have about you, that is in the public domain as well. NHS choices they use for NHS practices, and as I've said a few times, I imagine for private practices they're going to start looking at things like Google reviews and accreditation schemes. Seems to be something they definitely want to look at and are interested in. So if you imagine the CQC have essentially a score for your practice, like a credit score but a risk score, and at certain points, and that's the insight monitoring, and when that hits a certain point they're going to inspect you, you want to do everything you can to keep that score as low as possible. So how do you do that? How do you keep your risk score as low as you possibly can on insight monitoring? Well, the first thing is manage your online feedback. If you are an NHS practice and you don't look at your NHS reviews or respond to them, then I'd advise that you start doing that now, because the CQC look at it. If you're a private practice, then the CQC actually have very little information on you because you've not got an NHS contract, you're not on NHS choices, so that I imagine, I don't know, but I imagine they're going to be digging a bit deeper for private practices. So the most that you can do, encouraging people to leave online reviews for you. Some practices do this amazingly well. Software providers can give you things to do this, to do sort of ongoing surveys and to encourage people to write Google reviews for you. So deal with any complaints quickly. If you deal with a complaint that comes in quickly and resolves it quickly, then there's less of a likelihood of it being escalated to somebody who will tell the CQC in some way and it will affect your risk score. Manage your online feedback, as I've said. Have a professional, up-to-date website. I doubt that will affect your risk score, but when I go and audit a practice, one of the first things I do is I'll look at your CQC inspection report, I'll go online, I'll look at that, and I'll look at your website, because looking at your website does tell me quite a bit about the practice. About the leadership, about the quality. I can tell almost what a practice is going to be like from its website. And consider joining an accreditation scheme, and I'm going into more detail on why now. So I've mentioned this quite a few times throughout webinars, but if you sort of watch this history of the CQC's publication, then in 2014, when they published the provider handbook, they said that when they requested information ahead of inspection, they were likely to request membership of a accreditation or good practice scheme. I don't think they've actually been doing this. Correct me if I'm wrong in the text, but I don't think they've actually been asking for that. But this is the first time that it was mentioned, was in 2014. Now, in 2015, the CQC published a document called The Future of Dental Service Regulation, where the CQC sat down with the Department of Health, NHS England, the GDC, and one of the things they said specifically about private practices, though, was that they couldn't get information about private practices. It's very difficult for this insight monitoring to figure out what the risk score would be. I guess that's what it's related to. Now, what they said is that information about private practices could be addressed by greater use of established dental accreditation schemes. So they mentioned it then, again, a second time in 2015. And that made us think at Code, okay, we should launch an accreditation scheme for our members. Now what's happened this year, which is quite interesting, sorry, that should say 2000, oh no, well, it was December 2016 when they published it. But so what they said in 2016 when they published these draft key lines of inquiry is in the effective and the well-led, they've referred to accreditation schemes, recognised or approved accreditation schemes. Now, the CQC actually can't approve an accreditation scheme. They're not allowed to because they're a government body. So there's obviously a bit of a thing there where we're not quite sure how that's going to work. I am, however, going to have a meeting with the CQC to show them the quality practice scheme just so they know what we do and how rigorous it is. They won't be able to approve it or recognise it unless they're going to do something new. But they are looking to see if practices are taking part in accreditation schemes. So it seems they've mentioned this twice in the key lines of inquiry in 2016, they mentioned it in a 2015 document, and they mentioned it in a 2014 document. It seems quite apparent to me that the CQC want to inspect us less and want more information to help them do that. It seems obvious as a government body they're going to want to spend less money, especially in a time of austerity. So the more information we can give them to reduce that risk score, and the way that we can do that, I believe, is to join an accreditation scheme. And it's not only Code that are saying this, this is the interpretation of other people as well. So we have our quality practice scheme. So for those of you who are on the iComply application, you can join the quality practice scheme, which is a subscription-based service. We come to your practice once a year and we do an inspection, and then every quarter we log into your iComply and we look at how well you're using the investment, and we will write reports on it. To give you peace of mind, obviously peace of mind to the manager that people are using it properly, peace of mind to the principal, and obviously helping the principal stay up to date as well, as especially if the principal's a registered manager, helping them be aware of how the compliance is in their practice. So if you are interested in the quality practice scheme, then please type in the box or give us a call. We believe this is going to be really important. So self-regulation, moving on to this one, because I want to move on to questions in a minute. So the CQC said in the Future of Dental Regulation book, in the futures of dental service regulation, when they did this when they sat down and they spoke about how it was going to look, they said that there's a potential for some sort of a self-report or declaration. Care homes already do this. They already do one before an inspection. It's called a PIR, a Provider Information Return. And when the new key lines of inquiry, the last lot, came out for dentistry, it did look like we were going to have to do this, but then it didn't happen. Now it looks to me very much like this is going to happen, and it kind of ties in with this idea of the CQC probably wanting to inspect us less and inspect us more on risk and increase the period between inspections. HIW already do this in Wales. Every practice in Wales have to do an annual return as well. So obviously they mentioned it here in 2014 about doing that. They've also said in their strategy document that they're looking to identify annual activity for dental services. So they're still looking at this for dental practices. Not at information returns specifically. They're looking at what activity they want to do with dental practices on an annual basis. So they said that in this document here. Now, that doesn't necessarily mean they're looking at information returns. My interpretation is that that's what they're considering. And when I had a chat with them about it, they did say that they had been talking about it, and they'd sort of spoken to, I think, Adam and a few other organisations about it, and there was quite a positive response from practices about this idea of doing more self-regulation, which I think won't be a bad thing. And obviously for iComply members, if and when this does happen, we'll make sure that there's a very easy way to get a report out of the software that's going to help you to complete the report. So then what they have said in the December document, and this is specifically for NHS trusts, but what they've said for NHS trusts is that the provider information return that they'd asked for 20 weeks ahead of an inspection, they're going to start asking it once a year. So as of, I'm not sure when it's coming in for the NHS Trust, but they are now asking NHS Trust to send them an annual return. So I think care homes are doing it, NHS Trusts are doing it. So I honestly think very strongly that this is coming for dental practices. Again, it's just a prediction, but I can imagine, because they're doing it in Wales, that it will be coming. Right, so some actions. We're at the end of the webinar now. The next webinar, I should probably mention that, the next webinar is going to be on the 4th of July, on Independence Day. And I think Karen, our HR manager, is going to be talking about disciplinary and grievances and how to manage those and how to set up your policies and your procedures properly. And then you'll probably be back with me in August, or we might skip August and maybe September for a webinar on more compliance, CQC or HIW. One thing that's actually hot off the press, which I didn't mention earlier, there has been an update on the Research Council website to do with AED signs. The AED sign that you have to have up in your practice has changed. So everyone who's in this webinar, you may want to go to the Research Council website. I've only found out about this today, and you want to go and have a look at the AED sign that you're now required to have in practice, and you're going to have to change the one that you have up. So there's a new one up there, so you can find that on the Research Council website. So 4th of July for disciplinary and grievances. Actions, so there's nothing major you need to do now, more than sort of get your head in the way that things are going. But assess whether you're supporting your team members to carry out the more complex parts of their role and respecting their time. Or the practice is set up in a way that enables people not to be overworking all the time, because the CQC are going to start looking at that. I don't think those key lines inquiry are going to change, and assess whether or not you're supporting them. So if you have made someone your registered manager, your head of compliance, if you've made them your decontamination lead, what training have you given them to do it? Or have you just given them the role without the training? Consider whether or not you have good compliance knowledge, leadership competency and capacity in your practice right now. Do you understand the regulations? Are your roles clear in the practice? Does everyone know whose job it is to do certain things? Is that clear in your policies and procedures? And consider whether or not you should go on one of our events or to have some training to improve that knowledge. And also, as I said, if you're on iComply, maybe consider doing the leadership and management modules as well. Strongly consider joining an accreditation scheme. I think if there's one takeaway message from today, it's that accreditation schemes are becoming more and more important to the CQC. Start managing or encouraging online feedback. So not only managing your online feedback, but encouraging people to leave you reviews online. I think that'd be a very good idea, especially for private practices where the CQC will have less data on you. So you want to be able to give them more data. And just be prepared that you might have to refresh DBS checks next year. So if you've got those DBS checks that it takes about 8 weeks to get them, and these regulations come in April 2018, so maybe it takes up to 8 weeks, so maybe sort of February time you might want us to consider doing this next year. Right, okay, so thank you all for your time. Hopefully as I said, it's a big topic, so hopefully I've given you enough of an idea of what we think is going on and what might be coming. If you have any questions, then I'm going to stick around for the next 10-15 minutes or so, and please feel free to ask any questions.